So I decided to do the lung transplant procedure for the cardiothoracic surgery presentation. So what is a lung transplant? It is the procedure performed to replace a failing and or diseased lung with a healthy donor lung. The donor lung is taken either from a cadaver or an individual that has been declared brain dead. It can be a double or single lung transplantation, as these diagrams show. And then it has a lot of requirements that the patient has to meet. They cannot have a history of cancer, chronic liver disease, or kidney disease. They cannot be HIV positive. They cannot have hepatitis infection. They cannot have smoked tobacco within the last 6 months. They cannot have a history of alcohol or drug abuse. If they meet all the physical requirements, they also have to go through a psychological evaluation to make sure that they'd be able to keep up with the lifestyle changes and the medication regimen. It is a really big surgery to have, and they don't just give lungs away to anyone. So the anatomy that is involved is the right and or left lung, the lobes of the lungs, the bronchus, bronchioles, and alveolus of the lungs. Those are all in the lungs, but I just wanted to add those. The pulmonary artery and veins, the mediastinum, the trachea, which includes the trachea, esophagus, thymus, and lymph nodes, the heart and its greater vessels, the ribs, sternum, and thoracic spine, and then as well as the diaphragm. The indications for a lung transplant would be emphysema, chronic obstructive pulmonary disease or COPD, idiopathic pulmonary fibrosis, cystic fibrosis, and primary pulmonary hypertension. I added some diagrams to show what all of those things look like. Emphysema is actually a form of COPD, and a cystic fibrosis is a genetic disorder that affects the body's mucus buildup in not just the lungs, but also the pancreas and digestive system. IPF, or idiopathic pulmonary fibrosis, is a progressive lung disease that involves the scarring and thickening of the lung tissue. And then pulmonary hypertension is actually a pretty rare disease that affects the blood vessels in the lungs. So a lot of preoperative diagnostics have to be performed prior to a lung transplant just to ensure, first of all, that they're a good candidate. Obviously, an H&P, routine chest x-rays, blood and skin tests to check for those infections, echocardiogram, possible cardiac catheterization before, test to look for cancer. Another test would be a pap smear, tissue typing, and a psychological evaluation. And then before, if you prove to be a good candidate in all aspects, they'll have you go on immunosuppressants and antibiotic drug therapy before you even have the transplant. So surgical counts, I hope I'm right, but obviously your initial back table setup with the circulator, when they're closing the thoracic cavity, such as the sternum and I want to say hemothorax, and fascial closure, skin closure, and then extra counts are done if there's a change of personnel or a loss of supplies, and then sponges, sharps, extras, and then since you are entering the thoracic cavity, I would imagine you do count instruments. So positioning and positioning aids, supine. If the arms are normally extended onto arm boards with some foam, but if the patient has emphysema, their arms are typically tucked. Prepping and draping, the skin prep is from the mandible down to the mid thighs, and then bilaterally to the table. The groin region is also prepped for an arterial femoral line, as well as maybe a urinary catheter. And then also if a CPB becomes necessary. The surgeon might want to use plastic adhesive and a plastic adhesive incise drape, and then a chest or transverse laparotomy drape will typically always be used along with 4 blue towels. The incision is a clamshell incision along the mammary fold. As you can see, it extends from the mid-axillary region, and then it curves along with the sternum. This is for an open approach. There is a less invasive approach where it's just this portion right here on both sides. So the instruments that will be needed are thoracotomy instrument tray, general vascular instrument tray, bronchoscopy instruments. Long instruments are required since you're going pretty deep into the chest cavity. Hemoclip appliers, that just depends on the surgeon's preferred method of hemostasis. An ESU, cell saver for blood. You should also have the blood blank. You should also call the blood bank before the surgery to make sure that there is enough of the patient's type blood. Suctioning system, fiber optic headlight and light source, and then a defibrillation unit should be available in the room. Supplies, cardiothoracic back table pack, and all of this that comes with it. A cell saver tubing, 4x4 on sponge sticks, chest tubes, plurivac, vessel loops, 2.0 and 3.0 silk ties, as well as steel wires, pleated double arms, polypropylene sutures, vascular stapling machine, and this is for anesthesia, but it's pretty important, double lumen endotracheal tube. Okay, so the video that I chose is 10 minutes long and there's no way to quicken it. So I'm going to add the link in my discussion post, and I'll also link this presentation so you could just go into the presentation and view it. But it's not an animated video, it's a real video of a lung transplant. So for dressings, it's going to be a 3-layer dressing. You're going to have 4x4 gauze, ABDs, and then skin tape. The wound classification is a class 1 clean, which I don't know why I find that shocking, but I don't know. Medications, obviously the general anesthesia, the 1% xylocaine with epinephrine, that will be given at the end of the case to make the patient more comfortable when they wake up. Antibiotic irrigation solution, which will be used intraoperatively. And then afterwards, immunosuppressants, anti-rejection medications, antibiotics, antivirals, antifungals, diuretics, and pain medication. For the pain medication, they're probably not just going to give you Tylenol. They're probably going to give you some type of Percocet, depending on the patient, I assume. But immunosuppressants, anti-rejection medications, the patient, and actually antibiotics, antivirals, and antifungals, the patient is probably going to be on those for the rest of their life. Postoperative care, so the patient is going to be transferred to the CCU with the endotracheal tube still in place. They will stay in the hospital between 2 to 3 weeks. During that hospital stay, they will be doing deep breathing exercises to expand the donor lungs, TED stockings to prevent DVT, multiple chest x-rays taken while they're still in the hospital and then for the rest of their life. Full recovery is expected with no complications. A full recovery is expected within 6 to 8 months. Physical therapy, chest x-rays and blood tests for the rest of their life, anti-rejection medication for the rest of their life. The physical therapy is to get the patient used to the new lifestyle that they have to adapt to. And then some post-operative complications, surgical site infection, hemorrhage, if I could pronounce that, atelectasis, pneumonia, respiratory insufficiency, pneumothorax, which is a collapsed lung pretty much, pulmonary embolism, mediastinal shift, which is when the organs in your thoracic cavity shift from like the center to one side or the other. Acute pulmonary edema, or rejection of the lungs. All right, these are my questions, so I'll leave that up for a minute. And then this is my bibliography. Oh no, that should be italicized. Okay.